Welcome to Glioblastoma AKA GBM, a podcast brought to you by the Glioblastoma Research Organization, highlighting stories of GBM warriors, caregivers, medical advisors, and more. Join us this season as we connect with members of our incredible community and have meaningful and insightful chats regarding all things glioblastoma. Please note that any information provided on the show is not meant to treat, diagnose, or prevent any disease, and all information that is discussed in our conversation is what worked for the individual themselves and should not be taken as advice. The information provided on this show is not a substitute for professional medical advice, and you should contact your medical provider and healthcare team with any questions. Randy D'Amico, welcome to Glioblastoma AKA GBM.
Thanks for having me. It's a pleasure to see you, Amber.
It's a pleasure to have you on the show.
I appreciate you reaching out.
There's lots of things that we have to talk about, and I have a full list of questions, but I think the first one is, what is a day in your life?
Oh, man. Yeah, so I'm a neurosurgeon. I work at Lenox Hospital, which is part of Northwell Health. and I go to work 5 days a week like everyone else in the world. And I wake up early. A day in the life of a neurosurgeon is kind of juggling a lot of different hats, even though, you have one title of a neurosurgeon. But there's a lot of things we do every day, right? So first and foremost, I'm a husband and a father. So I wake up, I see my kids when I can. I go straight to work. I'm there usually by 10 after 5 because I live pretty close by. I get on a bike, I go to work. I was saying that, neurosurgeons, we wear a lot of different hats, even though we're doctors and we take care of patients, and there's a whole scheduled day of patient care that has to happen. There's a lot of other things that we do. So usually from 5 to 8 in the morning, really before anyone else is coming into work, that's when I do all of my research. And so, I'm super interested in what I do. I'm interested in the history of what I do. I'm interested in what are the problems with what I do and how do I fix those. And so I spend a lot of time reading and writing and doing clinical studies and looking at data to try to change how we do things, make it more efficient, have better outcomes, find new ideas out there, push the envelope in terms of what we're doing. And so, that's how I start my morning basically, with a cup of coffee and some research. OR start, around 7:45 in the morning. So if I'm operating, we're meeting the patient in the morning, we're talking to the family, we're having that conversation. We're in the operating room for however long we're there. Cases vary. It can be an hour, it can be 12 hours, So you try to schedule your day accordingly. In between, I'm responding to emails, I'm addressing things. We're on a webinar, not a podcast. Sorry, this is a podcast, right? People can only hear me. On the webinar, they can see me too.
See you.
Oh, really?
Yeah.
Oh, this is a full... this is a multimedia experience.
Multimedia experience.
So anyway, though, I do a lot of prep work for that. I'm responding to emails from my team. I actually give my email to my patients. And so a lot of times I'm actually responding to patients in the middle of the day, kind of throughout the day, and helping coordinate care amongst, a variety of different services that are offered. When the ORs are done and the patient care is done, if it's a clinic day, I'm done seeing patients, then it's usually some paperwork and catch-up time. Touching base with the team, making sure that everyone's got, their tasks assigned or, everything's sorted out. And then I go home and, again, I'm a husband and a dad. And so I read my kids to bed and put them to sleep and we eat some dinner and we hang out and then I do it all over again. And that's, kind of a 5-day-a-week job. Sometimes it's a 6-day-a-week job,
You mentioned before, not on camera, but privately, you mentioned that you used to be in punk rock bands. How did you transition from being in a punk rock band to deciding to be a neurosurgeon?
Yeah, it's a long time ago in my life. But basically in college, I realized that I didn't want to be a professional, really. I wanted to do something else a little bit different. I actually made a TV series about this. It was called Road Trip Nation. It came out in, I think, 2003. About me questioning.
Where can we watch it?
It was on PBS. It was an 8-part miniseries.
Oh, my God.
I think you can download it on their website. But the funny part is when you watch it, you're going to see a 20-something-year-old kid saying, I don't want to be a doctor. Everyone told me I got to be a doctor. I don't want to do that. I want to be in rock and roll bands forever. Mm-hmm. And so I did. I basically took time off after school, and I started a record label, and I booked concerts all around Manhattan and Brooklyn. And then my own band, we toured around, and we had a good time. And I remember as I was getting older, I was in that band for 9 years. And probably in my eighth year, we were on tour in Europe. Opening up for a bigger, band. It was their farewell tour. Mm-hmm. They were like 35 years old. And I just realized that these guys were playing the same songs they had written 10 years ago to like a new group of 16-year-olds. And it was terrible, right? Like they didn't believe anything they were saying. These 16-year-olds were 10 years younger. They had no business talking to them, really. Like, if it was on the street, it would have been a weird experience, to see an old guy talking to a young kid. And I was like, there's not a really great future here. They were like freelance construction workers as a job. All they wanted to do was get on tour and play to 2,000 screaming 16-year-olds.
That's wild.
And I was like, I need a fallback. And so neurosurgery was my fallback. In a way.
Okay.
But no, I came back home and I was like, you know what? I had a degree in neuroscience from college. I considered.
Now it makes sense.
Yeah, I considered myself a smart guy, or at least capable. Let's say that. And so I went and I treated it like a job to get back into medical school, and I did. And then, I had a degree in neuroscience, a minor in psychology. I loved the brain. I loved everything about it. And I thought neurosurgery has to be it. And then you learn a little bit about it, and you realize that neurosurgery and neuroscience are different things, right? Or at least it was, for a long period of time. And so then I tested out other fields in medicine. And I was like, all right, well, maybe I want to be a cardiothoracic surgeon or a transplant or a trauma surgeon, whatever it is. And I love medicine in general. I love the thought process. I love the thinking. I love how much we know about it. And but neurosurgery just stuck with me the entire time. And so I ended up becoming a neurosurgeon.
And here you are.
And here I am. And I barely play music anymore, which is the sad part. I listen to it constantly.
Okay.
Yeah.
I think that makes up for it. I also say, I can't function without music. If I'm showering, cooking, just anything, there always needs to be life is a music video, 100%. In my opinion.
Yeah, no, at all times. And the funny part now is with kids trying to get them to like bands, and you're like, dude, this is great. Why don't you like this? And they're like,
we want to listen to Baby Shark.
Yeah, they're like Baby Shark, or right now, Row 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 Your Boat is on repeat in my house.
Okay.
I want to.
You'd like to make a punk rock version of it.
I've done it. Please, I have a little acoustic guitar. The kids know 100 different versions of Wheels on the Bus and Row, Row, Row Your Boat that all end in screaming something.
Okay, baby steps.
Yeah.
So being a neurosurgeon, obviously, there are many, many different types of brain tumors, but obviously we're talking about glioblastoma. For those who don't know, can you share more about what glioblastoma is and how it differs from other different brain tumors?
Yeah. So glioblastoma is a very difficult disease. It's the most common primary malignant brain tumor, right? And people don't really realize how common it is because we don't hear about it on a day-to-day basis, right? You hear about, from TV commercials, mesothelioma, right, constantly. But mesothelioma is a really rare disease, right? GBM affects somewhere, and it's variable, between 1 in 4 per 100,000 people, right? So we're sitting right now in a city of 8 million people, right? That's a lot of people just in New York City alone, a 14-mile by 2-mile island, that are going to be afflicted with this, right? Just based on statistics alone. So it's a disease that comes from the brain itself. No one knows why it starts or how it starts yet. Okay, we're still figuring that out. But a cell, and there's theories on which cell it is, right? But it's either a stem cell or a progenitor cell, a cell that leads to the growth of other cells, becomes dysregulated somehow. And it starts to grow kind of uncontrollably. And what's unique about GBM, or glioblastoma, is that it recruits other cells into it. And so it's not just the tumor one cell that's replicating kind of at crazy speeds. It's bringing other cells that are normal in your brain and turning them into the tumor. And all these cells are now different. And it's not just pushing your brain away, it's infiltrating it. It's going through it. And so, the analogy that I always heard from one of my, someone who trained me that I always liked was that it's a plate of spaghetti and meatballs with tomato sauce. And there's that meatball, and you can think, I can get that meatball out. But if you had to remove all the spaghetti sauce, it would be impossible, right? And so that's kind of the way I learned about, how to think about this disease and how it infiltrates in the brain. The reason I say it's difficult is because the treatments to date have not been really successful, right? And so we've spent, the last 100 years trying to figure out how to take care of this. And we've made, incremental progress without a doubt. But not significant progress.
Yeah. Do you think that, at least since you've been working in this field, that you've found any new information that's come up that's been promising, or any new exciting treatments that are potential that you see could actually make a difference?
Yeah, absolutely. You have to remain hopeful when you're dealing with a disease like glioblastoma, right? The most important thing is what we've learned about the disease itself, all right? And so, every couple of years or so, we actually redefine how we classify these things. And if you were to go online right now and Google, and I'm sure people have done this, anyone definitely afflicted with it has, and, what is a glioblastoma? How long do I live with a glioblastoma? All these things, you're going to see this 14-month survival, right? And that's the average. But that average is based on studies that were done a long time ago that incorporated, all types of tumors that were called the glioblastoma. And there were some people who did well, and there were some people who did badly. And as we've gone further along with our understanding of it, and more specifically our molecular understanding of it, we realize that glioblastoma there's a lot of different types of glioblastoma, right? And so understanding the molecular classification, the mutations that lead to certain types of glioblastoma, helps us understand how people are going to do better and what they're going to respond to. And so, for instance, the standard of care now uses a drug called temozolomide. Mm-hmm. It turns out that if you have something called an MGMT promoter methylation, you're going to respond better to temozolomide than someone who doesn't. So all of a sudden, you have this fraction of people now that you can reassure that you're going to actually respond to your treatment better than this other fraction of people, mm-hmm. right? And there are mutations that do the opposite, that mean that you're going to do less well with these kind of things. And so that's helped us tailor our therapy. All right. And the work that needs to happen now is figuring out how best to tailor that therapy. But, the way that happens in the real world is research and clinical trials. Mm-hmm. And so in our current state, our current treatments that are accepted and approved, they don't do that. They're not tailored. They're a blanket treatment for everyone, And so it's that next step that's really important. Mm-hmm. But things like vaccines are coming down the line. These things are all in research right now. In addition to thinking about which drugs are important for glioblastoma, it's really important to consider how you deliver that drug to glioblastoma, mm-hmm. Because the brain is a very unique environment. Chemotherapy doesn't get there, and not a lot of people realize this, right? Mm-hmm. So only certain drugs are going to get in, and so figuring out how to get that really cool new treatment into the brain it's another part of the battle. It's another, point of intervention, and it's another unknown variable that makes it super difficult.
Mm-hmm. You mentioned talking about how there is ability to test for different biomarkers like MGMT. So what does that process look like? Is that something that's done during surgery, or how do?
Yeah. So right now, when you talk about the standard treatment of someone, so someone, let's say, God forbid, someone gets diagnosed with a glioblastoma, they see their doctor, they're evaluated. Almost certainly they're going to get a brain biopsy or a resection. All right. And that's because the data has shown that regardless of the size, gross total resection, meaning resecting all of the disease that we can see on an MRI, improves outcomes. Mm-hmm. And there's some data that says that even getting a little bit more might improve outcomes. That's a whole different discussion. But mm-hmm. right now, standard of care is as much whatever you can see on that MRI should come out. Right. All right. When that tissue comes out, we send that specimen for molecular analyses. And it takes, a week or two, depending on where you're at. The holy grail of this is actually being able to test your blood for these things. Mm-hmm. People are working on that constantly and actively through things like circulating tumor DNA or other markers that haven't been found yet, Mm-hmm. And then spinal fluid. The brain is bathed in this fluid, right? And you can actually access it through a needle in your back, mm-hmm. which sounds terrible when I say it out loud, but it's actually much more benign than a brain surgery, right? Mm-hmm. And we're looking for markers constantly in that too, mm-hmm. to be able to kind of figure out, is there a less invasive way to figure out what you have? But typically the standard is we remove your tumor, we send it away for some analyses, or we do it in-house depending on where you are. Mm-hmm. And then we get a report back that says all the pluses and minuses that you're going to have.
Got it. And speaking about surgery, before we started recording, I was asking you, what is an awake craniotomy like? Can you talk about that? Because I know obviously some patients can opt to be asleep. So What is the difference and how does it work?
Yeah, so the issue with an awake craniotomy, so the reason we do an awake craniotomy is when we're at risk where the tumor location, so tumors are or the brain, I would say, is like Manhattan real estate, right? Mm-hmm. Location is everything, or I guess real estate everywhere. And so every part of your brain, as you might imagine, has a function, or else it probably wouldn't be there. Mm-hmm. And there are certain functions that we consider, more important to your quality of life than others functions, all right? Not that we're ever really sacrificing function. We try our best to avoid that. But in particular, when things are arising in areas that control your speech or your ability to move half your body, all right, so the language areas or what's called the motor strip, those are really important functions to people. If you take away someone's ability to talk, then whatever life extension you've given them with surgery and treatment almost doesn't matter. Right. I mean, if they're unable to live a good quality life, you've really taken something away from someone. And so when we're in situations that we need to preserve neurologic function, the gold standard is to keep someone awake. And that sounds terrifying, right? But your skin gets numbed up, the bone doesn't really feel pain. The covering of the brain, something called the dura, has some nerve endings, but you numb that up too. And the brain itself doesn't feel pain. And so you can actually be wide awake talking to me with your brain exposed, being operated on. and you're, comfortable. And so we typically do this, in these situations. Definitely there are better patients for it than others. But if you do it well, if you have a great team, like my team's incredible at this, it's an extremely well-tolerated procedure. And so I just, what we were talking about before is I just did a patient, a couple weeks ago where after surgery, the guy looked at me and he said, I genuinely had a good time during surgery. He was like, it was so fascinating, so unique. They participate in tests while we're operating. So they're throwing questions at him, and it's like call and response kind of thing. He was telling us stories about The Last of Us, that show on HBO. He was talking about how much he liked it or didn't like it. I don't remember because I was doing brain surgery. So, but it's absolutely a unique experience. If you ever get the opportunity, you should come watch one. It's obviously like a little bit stressful. There's a person in the room and they're awake and they know what's going on. But we're very forthcoming with everything. We make it as pleasant as humanly possible. We play whatever music they want, and so, yeah.
That's wild.
Yeah.
I know my dad, when he had surgery, he chose to be asleep, but like that's wild that you can just like operate on someone's brain. I didn't know that brains don't the brain doesn't feel pain.
Brain feels no pain.
Is there like a reason why?
There's no nerve endings. It's all just information. Yeah. So the covering of the brain can, and local anesthetic lasts about 4.5 hours. So you have to work a little bit quickly in order to do it.
What happens like if there's surgery and let's say you're doing a awake craniotomy, but it doesn't get completed in 4.5 hours? Do you like re-numb?
Yeah, and, like, we have to.
Continue anesthesiology?
Yeah,
or anesthesia?
Exactly. So we'll either re-numb up the areas as best that we can, but you never get the same amount of coverage as the first time. Or honestly, we'll abort the procedure, we'll put them to sleep, and come back another time. Okay. Right? Because you can always go back. You can't put back stuff that you've taken out. So it is always better that a patient wakes up, fully themselves than it is to put someone to sleep, keep going, and do some damage.
That's fascinating.
The other important part about that people don't fully realize is that, we talk about risk factors with glioblastoma, right? What are your risk factors? So your age, being younger is a better, prognosticator. Your functional status, huge, okay? We call it a KPS, but it's a performance ability, right?
What does KPS stand for?
It's the Karnofsky Performance Scale.
Okay.
And it's a measure of how independent you are with your living for the most part. There are things like the mutations. I can't change the mutations. I can't change your functional status when you come to me, right? If you have weakness from the tumor or you can't speak from the tumor, I can't change that. That's how you came to me. But it matters. The thing I can change is your surgery. So the extent of resection matters, right? So doing a aggressive surgery and taking it as much as you can, that's been proven to change your life expectancy. If you hurt someone, you eliminate that benefit. So if someone's quality of life goes down, you leave someone with a permanent deficit, you've taken away that advantage that your surgery was going to give them. And so the goal has to be safe maximal surgery, always. And we've got a bunch of tools. I don't know if I probably talked to you about some of them offline, but we can do awake surgery, the gold standard, right? I know that if you're tapping your finger in that operating room, when you wake up, you're going to be tapping your finger or you're going to be talking to me. We use complex imaging, right? We have something now called connectomics, which allows us to look at brain networks and functional networks and map them out before we even go in your head. We have a GPS system for the brain. It's called navigation. It gives us millimeter accuracy in terms of where we are. We have things like ultrasounds in the operating room, but probably the most useful is fluorescence guidance, where there's a drug you drink right before the operation, and in the operating room, it makes the tumor cells alone glow bright red.
Wow. And
so all of a sudden, I'm looking at your brain, and I switch on my light filter, and all of a sudden I see a big red target, and I know that that's where the key is. And so you use those things all together, and you make sure that you're going to maximize your resection while preserving someone's outcome. And that's, again, knock on wood, I've been very fortunate. I think we do an amazing job at Lenox because we use all these things. We use each other, our experience, but all these tools also to make sure that people are going to wake up all right.
Absolutely.
Yeah.
That's incredible.
I mean, GBM's stressful enough. Imagine having to wake up from surgery and be like, my arm doesn't work now. Like, what
does it feel like for you to have that responsibility that, you are operating on someone's brain?
Yeah. I wish I could say that, you're numb to it because you're an expert. This is all you do, but it's nonsense. Every single case like this, when there's something at risk, you think about your career choices before you go in that operating room, right? And especially when you're waiting for someone to wake up at the end, you have to tell yourself the truth about what you're doing. When you do a safe surgery, you get someone a diagnosis, you give them that longevity, you give them that quality life with their families, you change their life for certain, right? Because there's this consideration of what you're dealing with, right? which we can talk about another time about the philosophy of what it must be like to know that you're going to die. But the responsibility is something that you're going to take on, and you just kind of embrace it and go with it. I learned so much from every one of my patients. It makes my entire life better just to watch people go through something like this. So,
how does a patient, let's say that comes to Lenox Hill, how do they decide which doctor they work with? Because obviously there's an incredible team of incredible physicians. How do you decide like who you're going with?
It's a great question. I think they go to the guy who takes his shirt off on TV for the most part. No. It's a lot of word of mouth, who you get referred to.
Okay.
It has to do with, we're subspecialized to a degree. So I really only do tumor surgery. So brain and spine tumors. And even within that, I've even subspecialized a little bit more where I do everything, but I really focus a lot of my research and my efforts on brain and spine metastases.
That's my next question.
Oh, good. All right, we'll get there. But, I for complex functional mapping and glioblastoma surgery, I do it and I enjoy it. I think patients look for their doctors for referrals. I think it's important to do your own research. And if I was going to give advice, I would say, look at how exposed someone is maybe in that field. Like when you Google their name, what comes up? If your surgeon says first and foremost he does like spine surgery, and then at the bottom it says glioblastoma, he's probably not a glioblastoma guy, right? People who tend to do this are really invested in it. If it says that he's a brain tumor specialist and that's first and foremost, and he does everything is around brain tumors and his research is around brain tumors, then you have a better sign that this is a guy that you can trust, or a person, a doctor that you can trust. So I think that's kind of the way it goes. For me, and we were, I'm early in my career. I'm about 4 years into practice. My outcomes are my currency, right? So the way I get more patients is by my patients doing well. And then their family members see that, their friends see that, their doctors see that, other doctors see that. And so having a patient wake up perfect and having a scan that looks good and giving them that maximum benefit with the things that I know I can change, not their moleculars, I can't do anything about that. That's how, your name gets out there and people recognize that you're doing good work.
That makes sense.
Yeah.
And so you recently launched the Brain and Spine Metastases program at Lenox Hill. Can you talk about that? What made you want to do it? What do you guys focus on? And what's the goal of the program?
So I came to Lenox, in 2019 originally, and John Bookvar, who's my senior partner, was running the brain tumor program. He was really doing everything himself. And John's a phenomenal surgeon, super smart guy. He does tons of research, clinical research on glioblastoma and brain tumors in general. When I got there were actually clinical trials for certain metastases as well. And I sat down with John and I said, look, man, how can I help you? Where can I branch off here and we can create centers of excellence within these two, within the worlds of the brain tumor world? Brain metastases are 5 to 10 times more common than glioblastoma.
And so just to pause really quickly, what is a metastasis?
So
if anyone's listening that doesn't know.
Yeah, no problem. Sorry, I jump the gun sometimes. So a metastatic tumor has to do with a primary cancer. So if you have lung cancer, breast cancer, melanoma, these tumor cells can break off into your bloodstream and they can travel through your body. And so you'll hear all the time about, oh, I've got cancer in my liver now, but it started in my lung, right? So that's a metastatic tumor. The brain keeps itself pretty safe, but some of these tumors can actually mutate and get into the brain. And so if you were to look, 30 years ago, a brain metastasis was palliative. People would say you're at the end stage of your cancer, that's stage 4 cancer. There's nothing more we can really do for you. The chemotherapy is not going to work. Or they would give you whole brain radiation, which it turns out is not really great for you. It has all these cognitive side effects. And so people would kind of give up on these patients. As our whole entire understanding of cancer has changed in the past, 5 to 10 years, we've realized that, oh, wait, no, we have options here. And so we've developed things like stereotactic radiosurgery, which is a targeted, focused beam of high-dose radiation that's super safe. It doesn't have the cognitive deficits that, whole brain radiation would. And the control rates on tumors is fantastic, right, in the brain, okay? We've figured out that certain tumors in your body, certain lung cancers, breast cancers, have mutations that we can target with specific drugs that aren't through a port and making you sick and lose all your hair and, vomit every day like movies would show you. It's a pill. And the control rates there are incredible. And so we've extended cancer survival, on average, probably, 5 years, 6 years. The percentage of 5-year survivors with cancer, all comers, is projected to increase by like 30%.
Wow. In
the next, 10 years. And so all of a sudden this group of people, which were originally thought as palliative, we're not going to do anything, you're at the end of your game, we've got options. And so there's a whole subspecialty now here where we can look at that. And so I've got a brilliant medical oncologist who works with me. Her name's Marana Vojnic. I've got a brilliant radiation oncologist, and we kind of created this group. John's involved, some of my other colleagues, and we created this multidisciplinary experience where now you come in, you're seeing your team. It's all of us are getting involved, and we're sitting down and we're discussing your case, and we're figuring out exactly what you have, what are your options, what's the best for you, your social situation, everything. We consider it all, and then we come back to you and we present that plan. And so it's been amazing. I love doing it. It's a great patient population. They're super thankful. And I think we're doing work that is on par with the top cancer centers in the country. We're opening clinical trials now for brain tumor specific patients, so patients with brain metastases specifically.
Congratulations.
It's a real win. And realistically, it decompresses John, so John can focus on his glioblastoma clinical trials. And so we all cross-pollinate a little bit, but it allows two kind of ambitious people to focus. And if you have two ambitious people focusing, it's much better than one.
For sure.
Yeah.
Biodexa Pharmaceuticals is proud to sponsor the Glioblastoma AKA GBM podcast. Biodexa Pharmaceuticals is a small biotechnology company hoping to make a big difference in the treatment of glioblastoma. Using their proprietary nanotechnology, Biodexa is developing liquid formulations of an investigational drug which can be delivered directly and locally into the tumor via an implanted catheter. This drug has been previously investigated in pediatric patients with brain tumors. Biodexa Pharmaceuticals is currently running a clinical trial in patients with recurrent glioblastoma known as the MAGIC G1 trial. To find out more about the MAGIC trial, visit magictrials.com. Imagine waking up from brain tumor removal surgery knowing that your radiation treatment is already underway. That's how gamma-tile therapy works. At the end of brain tumor removal surgery, the neurosurgeon implants the gamma-tiles where the tumor is most likely to return. So instead of waiting to start daily standard radiation treatments that go for weeks, you get a head start against tumor cells and get back to your life sooner. For operable brain tumors of all types, including glioblastomas, brain metastases, meningiomas, gamma-tile therapy is a one-time, targeted radiation treatment with fewer side effects and a far less chance of hair loss than external radiation. Gamma-tile therapy is tough on tumors and easier on patients and caregivers. Learn more at gammatile.com. Gamma-tile therapy is an FDA-cleared radiation therapy for patients with newly diagnosed malignant brain tumors and recurrent brain tumors. Novacure is pleased to support the Glioblastoma AKA GBM podcast. Novacure strives to extend survival in some of the most aggressive forms of cancer through the development and commercialization of their innovative therapy called Tumor Treating Fields. Novacure partners with the Glioblastoma Research Organization to work together on behalf of patients and their loved ones impacted by GBM. To learn more, visit novacure.com. Roon was built by a team of patients, caregivers, and medical experts, consisting of neurosurgeons, neuro-oncologists, psycho-oncologists, radiation oncologists, nurse practitioners, and social workers who have devoted their lives to treating and helping glioblastoma patients. For anyone navigating GBM, Roon offers a wealth of medically vetted, digestible video answers to common questions. Answers are organized into major topics ranging from surgery to radiation to caregiver mental health. Check it out at roon.com. How important is like a multidisciplinary approach when it comes to brain cancer? Because obviously, you can just get surgery and then you can do treatment, but how important it is to have that multidisciplinary team?
Yeah, you really need a team. You need a team-based approach no matter what. It goes back to that argument, if you Google your doctor's name and he's a spine surgeon and he tells you one thing without including anyone else's opinions in that, not saying spine surgeons are bad surgeons, they're great people. Some of them are probably great tumor surgeons, but you want to know that you've got a team of people that cover every different aspect of your care, right? Mm-hmm. Because glioblastoma care is not just surgery. It's treatment. It's chemotherapy or different chemotherapies. It's radiation on top of that. It's your social needs afterwards. You want that team to consider every aspect of your care. And on top of that, because there's no single answer for every case, you want multiple experts to weigh in. Mm-hmm. Because sometimes your treatment plan will change based on that. It's almost like an internal second and third opinion, right? Or fourth or fifth or ninth, depending on how many people are on your team, right? Mm-hmm. And so I think that in general, just like you go doctor shopping, right? Like, well, this guy told me this. I want a second opinion from this place. You get that internally. And it's super useful. Having a multidisciplinary team is the standard of care. And if you're not getting that, you should probably go somewhere else.
For you, how involved are you with your patients? You know, obviously there's different members of this team if someone comes to see you as a patient, but like, what does your communication look like? Obviously someone comes to see you if they're diagnosed and then you have surgery. Like, what is the full involvement from beginning to end?
I'm obsessed with my patients.
Okay.
All of them. Yeah. You know, for better or worse. So I give everyone my personal email. I used to give out my cell phone number, but patients will call in the middle of the night, and it got a little dicey with, you know, the family situation. So I give my email now. I tell them when I meet them, I will not answer you between 7 p.m. and 8 p.m. because I'm putting my kids to bed, and I sleep from 10 to 5, so you're not going to get a response overnight. But the minute I wake up, you'll get a response. I CC my nurse practitioner. Her name's Taylor Wimby on everything. She's incredible. She talks to these patients every single day. I see my patients twice a day when they're in the hospital, and when they go outpatient, we communicate. You know, I know every step of the way what's going on. The other good thing about having a team, though, is that you're not the only person doing that, because it can be overwhelming. People have a lot of questions, right? There's not a lot of information about this disease out in the world. And so having a team that you trust, who you can be CC'd on that email, right? But the information, you know, is still going. The communication is still there. That's absolutely critical. But no, I like to be as involved as possible. You know, where I trained, we would actually do surgery, and then the neuro-oncology team would take over the patient, and they would disappear for a while, you know, until either they had a recurrence or a progression, or there was a specific question. At Lenox Hill, we see our patients, you know, on those every 2-month visits, and you know, it can be burdensome at sometimes because you have a lot of doctor's appointments, so we try to accommodate that. But for the most part, I think it's super important just to be involved. So you also learn a lot about the disease when you see your patient that often.
Yeah. So. I think it's fascinating that, well, when we first met last year, we hosted the Project Rush launch dinner, and we were talking, and I remember it was fascinating that I think I specifically mentioned to you that you're very involved as far as, like, you know, I don't disruptive is not the word, but you used it before we went live, but like, you're very communicative and doing more, you know, social media, and you're very, I guess, I don't know if like out there is the appropriate word, but like you're much more open, right, than I guess many people would say that, like, you know, a neurosurgeon would typically be. And I think that's fascinating. It's great to like know that, you know, obviously you're so involved with your patients, but also like you have your TikTok that we talked about, and like Instagram and everything. But aside from that, you also have a webinar called Tumor Talk, and that which is in partnership with the Journal of Neuro-Oncology. Can you share more about that and what you do and what the plans are? Yeah,
absolutely. And yeah, no, we are very out there. We like to expose ourselves, I guess. And it's I think it's super important. I mean, first of all, we live in a world where there's no more, you know, I grew up in like a subculture, right? I was like obsessed with punk rock music and rock and roll music, and it was like a subculture. That doesn't exist anymore, right? Everything is online immediately. Everything is global immediately, right? And I think what I do is pretty damn interesting. That's why I like it. And in a world where there are little pockets of people doing interesting stuff in all these worlds, why can't what I do be interesting and you know, and encounter people who like it, you know, and appeal to them in a way. You know, we're super safe about patient safety and rights and whatnot, but it's so important, I think, to expose what we do also, so that people can see it's not rocket science. It's neurosurgery, as the joke goes, I guess. As for Tumor Talk was, it started during COVID. You know, when COVID hit New York City, the hospitals just shut down. And to be honest with you, all of us super ambitious people had nothing to do. We were just standing there, and we were like, we got to do something. And Dave Langer actually was kind of the figurehead of all this. And he was like, we will not sit around and do nothing. We need to take over New York City, and we need to fix COVID and, you know, cure it and cure the world and everything. And we all just got busy doing individual things. And Zoom obviously became like a big component of everyday life during COVID.
Yeah.
And
it's crazy how like it was huge for like 2 years, and now I feel like everyone's like not Zoom.
Yeah, no,
like,
everyone's doing everything
Meets,
else
like
now.
FaceTime, everything else but Zoom. It's crazy.
Everyone else caught up, I guess. And so, but that ability to provide multimedia globally, rapidly, easily, all of a sudden came out of nowhere. And we said, all right, let's do a webinar. And the first one was going to be, it was COVID in the brain. And it was just kind of basically, my idea was go to my cancer patients, glioblastoma patients, regular cancer patients, and reassure them, you know, that we're still there for them. The resources are still there for them. Their treatments are still there for them. how to be safe during this. And I interviewed oncologists and social workers and, nurses and people on the front lines and patients and all this stuff. And, as we kind of worked through COVID, I realized, there's a little bit of a platform here. Mm-hmm. It's super easy to do. And so I was like, all right, let me go to the Journal of Neuro-Oncology, which is the official journal of the joint tumor section. So we have organizations, the AANS and the CNS, mm-hmm. and there's a joint tumor section full of it's called the executive committee, full of neurosurgeons who make the decisions on brain tumor research, basically, and, mm-hmm. and the standards of care and whatnot. And I went to them and I said, look, I want to change my webinar, and I want to highlight publications in the journal, and I want to make it approachable mm-hmm. for patients, students, researchers, everyone. Most importantly, I just want to read these journal articles. I'm reading them anyway. I might as well talk about them with the guy who wrote it and ask my questions, right? Rather than just thinking in my head about, mm-hmm. what they were asking. And to my surprise, they were like, yeah, okay, no problem. Let's do it.
Here you are.
Yeah. And so we started it, and I think we're something like 50 or 60 webinars deep now. Mm-hmm. And we've had, world experts in the field. We've gone international. We've had people from, Japan, from across the pond in Europe. And it's amazing because I get to sit down with someone and they get to tell me the rationale for their study, the mm-hmm. results of their study, and the relevance, right? What it's going to do in the future in their own words. Mm-hmm. And all of a sudden, I feel smarter at mm-hmm. the end of it. I get my questions answered, and I get to meet all these people who I can collaborate with. And then the best part about it is it's open. So for patients, if they want to hear about a certain topic, or they maybe don't understand what's going on in that journal article, they log in and we break it down pretty straightforward for everyone, all viewer types. So yeah, no, it's been a tremendous experience, actually. Jason Sheehan, who's the editor-in-chief of the Journal of Neuro-Oncology, has been a huge supporter since the get-go. He co-hosts with me about 99% of the time.
You guys interviewed me.
Yeah.
It's funny, I get to interview you now.
I know.
It's like roles reversed.
I know, I'm scared.
You should be.
Yeah. No, I mean, he's a great guy, and he's a super smart guy. Mm-hmm. And I think what you're doing with this is a similar thing, which is that there is a platform and there are people who will listen. Mm-hmm. And typically those people who are going to listen are people who are looking for something, right? And whether it's a family with a family member of a glioblastoma, or a patient with a glioblastoma, or just a medical student interested in this field who's going to either of our whatever we're putting out there, mm-hmm. it's important. Yeah. And it's an ability to convey information. Yeah. It's easy.
Well, congrats on all the success. I mean, 60 episodes, that's incredible.
Yeah, it's been a while.
It's very exciting. A lot of new things coming up. But going back to being a neurosurgeon, what do you think is the hardest part about it?
The hardest part about being a neurosurgeon is the unknowns, I think. Surgery doesn't always go the way you want it to, right? Anyone who told you they have zero complications is lying to you. Mm-hmm. There are complications. And sometimes it's not surgical. Sometimes a patient wakes up and they get a blood clot and it goes to their lungs, and all of a sudden they're super sick, and you're like, what? I did everything right. I don't understand, Mm-hmm. But there are times where you do everything right and still stuff happens. And that is always an extremely difficult situation. It shakes your confidence, right? Regardless of what anyone you talk to says, even me, who I probably look like not that confident on this camera, I don't know, but but I'm confident. I'm very good at what I do. But there are times where it doesn't go right, mm-hmm. and it shakes you and it rocks you really to the core, and you sit there for a week or a month, depending on how bad it is, and you say, am I doing this right, or did I get too cocky? What should I have pulled back, or should I have gone forward? Did I do the right thing? Those situations are always extremely difficult. Mm-hmm. But more so than that, it's the patients always. And so when you do your best, right, and someone still succumbs to the disease, mm-hmm. that sucks, mm-hmm. right? And that's what pushes us to be involved in research. That's what pushes us to look that a little bit better at this stuff and say, well, maybe we're asking the wrong questions, or maybe I'm not doing enough, And it kind of goes back to what your goals are. But if your goal is to help people, and people aren't being helped, or if you aren't doing enough to help people, then you're failing at your goal, mm-hmm. right? And you have to kind of balance that in your head. And it's I don't want to curse, but it's something that you do to your mind.
I've cursed a lot on the show, which
I
really get some backlash for.
Well, it's a mind.
But we're also people.
Yeah, we're humans. But anyway, so those are kind of the biggest challenges. Mm-hmm. And then I would say the other one, which is a totally selfish thing, is I want to do a million things, mm-hmm. and there's not enough hours in the day, because mm-hmm. I sleep from 10 to 5, and I shouldn't. Mm-hmm. I should sleep from maybe 12 to 1 or something.
Sounds a little aggressive.
No, I know, but there's so much to do. There's so many ideas out there. And, if neurosurgery moved at the speed of tech, right, things might be different, right? But there's regulations and there's hurdles, right?
Yeah.
Funding for research, for instance, is hard to come by. And the grant process and review process takes time. And so you get in these lags of kind of how fast you can get things done through red tape and whatnot. And that's why when I say that Lenox Hill is disruptive, it's because we kind of push the limits of that kind of stuff.
Which is amazing.
We're kind of an act first, ask questions later kind of thing. But we follow the rules. We do things safely. But I mean, if you sit there waiting for someone to tell you to go ahead, you're going to be waiting a long time. So
how would you feel like, or not how would you feel like, how do you personally manage stress inside the operating room and like outside the operating room?
Yeah, well, John actually and I have talked about this a lot. I had a complication early on in my career where John actually was walking by and he saw me struggling a little bit. There was a torn blood vessel. It was a pretty important blood vessel, and he came in to help out. I afterwards I remained actually completely calm. I knew what I needed to do, but there's no way to deny that it's a stressful situation. And John came in, and after he helped me out a little bit, we got everything under control. At the end of the case, he came in. Woman did fine, by the way. John came in and was like, man, he's like, I just want to say you handled yourself perfect. And what he meant by that was that you actually you can't panic, no matter how bad something gets, because if you panic and you're the captain of that ship, everyone panics. And when other people panic, the right things don't happen. So what you need to do is you need to just remain calm. You need to trust your training, right? And you need to say, you need to delegate. All right, I need you to do this very clearly. So you have to stop and think, and I need you to do this very clearly, and I need you to do this, and I'm going to do this. And all together, if we remain calm, we're going to get that stuff done. And so you kind of shift gears a little bit. You've never been in the operating room with me. I'd love to have you come by.
I think that'd be so much
fun.
We
have visitors. We have students rotating through all the time, and we can bring in visitors without a doubt. Yeah, we'll get you all your qualifications and everything. We'll bring you in. And I'm very chill in the operating room because, like I said, I'm very confident about what I do. But you shift gears when that happens. All of a sudden, the music goes off. Everyone has to focus. And so you do that.
What about personally? Like when you're off work, like how do you de-stress?
Nothing else stresses me out.
Really?
Yeah. So this is a luxury that, I have. Look, I deal with cancer on a daily basis, whether it's a glioblastoma or a metastatic cancer. I deal with people who are facing their mortality every single day. And some of those situations are, a 90-year-old person who's lived a very full life. Some of those people are 30-year-olds who have not lived a full life and whose life I've outlived, right, in my 41 years. It makes you incredibly grateful for everything that you have in your life. And so, if I come home and there's, I don't even know, I'm trying to think of what stressed me out recently.
Toys all over the floor?
Yeah, if my house is a mess, right, it's okay. Like I'm okay, right? We just get through it one step at a time. We go through it. Yeah, no, I don't get too stressed out about a lot of things anymore, and I think my job changed me. I'm pretty calm about most things. Look, if someone in my family's sick, I'm going to be stressed out, right? But at the same time, there's a process to all this, and again, an understanding that nothing's going to get fixed immediately. Let's stop and think our way through, and let's figure this out. So.
I always feel like every time I do a podcast, I always get gut checked. It's like I stress out a lot about very minor things. And I always interview someone, whether it's like, a neurosurgeon or a doctor or a patient with glioblastoma or a caregiver, and they all just give such good advice. And I'm just like, here I am, like stressed out that like, I don't know, that like my Uber Eats was like 5 minutes late. Like it's nonsense. It's really
don't get me wrong.
It's a good gut check for sure.
I don't like being late to things. I wouldn't say I get super stressed out about it, but I don't like being late to things. I'm always kind of on time.
You were 20 minutes early today. I was like, I'm not even here yet.
I was
sorry.
You weren't even in the state yet. I think you were still in the air.
I was still in the air.
No, but I think I was taught at a very young age, early's on time is late, and late's unacceptable.
Because you grew up in New York.
Yeah. So I grew
up in Miami, where it's like something's at 8 o'clock, you show up at 10:30.
Yeah.
Which is the worst, by the way.
No, I've been, those kind of things don't bother me anymore. They used to, though, but without a doubt. But I think I just got a lot of perspective. I get a lot of perspective. Like I said, I learned something from every single one of my patients. Every single one. And every case teaches me and reiterates that whole thing about, gratitude for what you have. Look, I could get sick tomorrow, right? We've all seen it. I've seen people my age, younger, older, everyone gets sick. And so why waste my time thinking about things that aren't going to affect me like that could, right? Mm-hmm. So just enjoy yourself.
Here I am, just like mental notes. Go ahead.
No, I was trying to think. There was one more thing I wanted to say about it, but I forgot. So I'll bring it back later.
Sorry for cutting you off.
No, that's good.
Is there one particular case that you've worked on that was the most memorable, or that you maybe learned the most from, that just like highlights in your head?
No, it's a great question. I remember a lot of my cases because I learned so much from them. Mm-hmm. I think what we're doing with complex neuromonitoring is the stuff that I really kind of dwell on nowadays. So myself and my neuromonitoring kind of person, his name's Justin Silverstein. He's a PhD. He's brilliant. He does all the neuromonitoring for our cases at Lenox. And I met him when I started there. And at first I kind of shrugged it off. And then it turns out that he was in punk rock bands and I was in punk rock bands. So we started talking.
You guys were immediate best friends, obviously.
And then it also turned out that he's just obsessed with pushing the envelope in neuromonitoring. Mm-hmm. And one day I remember talking to him and I was like, hey man, I was like, they make this instrument but you can do monitoring through that. And I want to be able to monitor the brain through my operative instrument. And he was like, I can make that. And I was like, really? And he was like, yeah. I was like, all right, let's make that. Wow. And so we put together really a hodgepodge of instruments. They make one commercially, but it's like $90, and it's a suction device, but it comes in a diameter suction that I would never use. It's wimpy. I don't like wimpy things. I use a lot of big suction and high heat in my operations. And so we made one just out of some like instruments that we could find in the OR. It's all sterile. We electrify my suction. It's completely modifiable. I can design it however I want. And then we're able to monitor your brain function while I'm operating. And wow. It's called dynamic subcortical stimulation. You can use it on the cortical stuff too. And so basically when I'm operating on someone who has like something affecting their arm function, right? I can find that region of the brain with my suction, just touching the brain with it. Then I can start my operation and we change the amplitude of the electrical stimulation through that suction device. I don't want to get too technical, but as I get closer to your functional area, mm-hmm. I get notifications. So all of a sudden I can like shave away millimeter by millimeter of tumor to really maximize that surgical result, mm-hmm. And preserve your function.
That's incredible.
And so you combine that with the fluorescence, with the connectomics now, which I'm super obsessed with, and the operations become this incredibly dynamic kind of like super interesting experience. Mm-hmm. And I live for those cases. I love an awake surgery. I really do. It's just, again, that's, it's kind of the utmost of what we do. And so, yeah, those are the ones that I really think about. And obviously you never forget complications, like for the instance, the one we were just talking about mm-hmm. with when John came in to bail me out. Fortunately we were able to get control of that situation. That's a situation where you never forget it, right? Because mm-hmm. God forbid you ever encounter that again, you actually have
the biggest learning experience.
You got a roadmap of how you're going to fix that problem, right? And so, there's a lot of cases. There's no standout one case. You learn a lot and you put them in these folders of this is what I do here, this is what I do here, this is what I do here. Mm-hmm. But if I had to choose, the monitoring stuff we've really pushed the envelope with it. It's incredible.
That sounds fascinating.
I would
love to watch it one day. Super cool. Is there any advice you would give to someone that's interested in pursuing a career in neurosurgery or neuroscience?
Yeah, you have to be in a punk rock band for 8 years first. Okay. And then, get
you
tattoos. You
heard it here first, ladies and gentlemen.
Yeah, get a bunch of tattoos, and then you're a neurosurgeon. That's it. So you have to play in basements throughout Brooklyn and other weird towns in the United States. Then you're a neurosurgeon. It. Yeah, that's training. No, look, it's an incredible career. Medicine in general is an incredible career. Mm-hmm. Should we stop for a second?
I think it adds character.
Yeah, if you're cool with it, I'm just like, I could hear them coming down the street, and I could tell her to just keep getting louder and louder.
It's probably my mom calling the police on me for saying that kids should join punk rock bands and get tattoos. She wasn't thrilled with that whole experience.
Do you have any tattoos?
I do.
Oh, okay.
I've got a few.
I've always wanted one, but I'm like terrified of needles.
You know what? Honestly, I probably would tell you not to do it now. Mm-hmm. When I was younger, I would tell you to do it, but now I think, the problem is they don't come off.
Well, yeah.
Yeah, no, they're permanent.
Yeah,
like legitimately so. And then you get older, and things tend to they kind of look different, right? Like when I was 21, I looked good. Now I'm 41. I don't look as good. My tattoos looked awesome when I was 21. They did. Now, It's like, yeah, it's less cool.
So what would you tell a neuro student?
Anyway, yeah, so medicine's incredible. All right, the whole field of medicine is incredible. If you wanted to be a neurosurgeon specifically, I would look a little bit into it, right, and understand why you wanted to do that. All right, brain surgery encompasses, or neurosurgery encompasses a lot of different things. 70% of neurosurgery is spine surgery, right? We do things like clip aneurysms and take care of vascular patients. There's a whole world of minimally invasive endovascular approaches, right? Tumor surgery, or brain tumor surgery specifically, is a subspecialty of this. So you make sure you understand what the field is about. Make sure you're really passionate about it. The world has changed a lot in medicine, and gone are the days of like, I went in on a Friday and I didn't leave till Monday morning kind of thing. That's illegal now. We've realized that that's super dangerous. And there's a huge push now on the mental health of residents and doctors in general, because for years it was, it's an emotionally and psychologically taxing profession for all the reasons I just said, right? I'm remarkably well adjusted, apparently. But no, seriously, it's a stressful job, and if you don't have that support, group that you have with your family or whatever it is, it can be really, really stressful. So make sure that it's the right thing for you. We've made the job tolerable, and we've made the job of becoming a doctor better. All right, it's more doctor focused in terms of all those qualities. And then I think just like anything else that you want to do, put in your 10,000 hours. Want to become an expert at it. It's not a job, it's a career. And that's a difference with that, right? Which is something I learned a lot later in life. A career is something that, like, my hobby is neurosurgery. I'm obsessed with this stuff. I think about it all day long, every day. And that's okay by me. Like, I really enjoy what I do, and I really enjoy how I do it. And if it gives you that vibes when you're thinking about a career, don't do it because you want to make money, right? Doctors don't make money anymore. We're fine. Don't get me wrong, we're fine. But we don't make what we used to make, right? That's not a reason to do this. The reason you do this is because you want to make a difference in individuals' lives. You want to enjoy what you do. You want to have a fulfilling career that's always going to be changing. You're going to always feel like you're playing catch up with what's actually happening out there. And you do this for the enjoyment it gives you, the kind of fulfillment you get out of it. And so if you check all those boxes when you're applying, then do it. I don't think there's a better job. I think it's absolutely incredible. We do the wildest shit.
I love that. Well, thank you so much for coming on the show. It's always such a pleasure to chat and hang out with you. So yeah, thank you again, and for sharing your story and for being
me.
Punk rock neurosurgeon that's relatable to talk to.
No, thanks for having me. I think that, again, what you're doing is incredible with this, and I wish you all the best with this podcast and your next podcast. And if you ever need us all on together, it would be absolute pandemonium.
That would be
the whole crew.
Funnest episode,
it would be bananas.
I think, ever.
Yeah, I can't rein in any of those maniacs, so it would just result in pandemonium.
That would be awesome.
But no, I really do sincerely appreciate it. I think you're doing a great thing, and I look forward to seeing more podcasts from you and more.
Thank you. Appreciate it.
Thank you.
Cool.
Good.
Woo.
Thanks, man.
Thank you.
We got everything?
That was fun. That's it for this week's show. Thank you so much for tuning in again to another episode of Glioblastoma AKA GBM. To get in touch with our organization, visit us online at gbmresearch.org or visit us on Instagram or Facebook at Glioblastoma Research. Visit us on Twitter at glioblastoma.org or visit us on LinkedIn at Glioblastoma Research Organization. To make a donation to the organization, which is fully tax deductible, visit us online at gbmresearch.org, where you can designate your donation in honor of someone or find other methods that you can make a donation with. Thank you again for supporting us, for supporting the show, and we'll see you next week. Welcome back to another deep dive with Stash Strong. Today, let's talk about this episode with Dr. Randy D'Amico. What was your favorite part about it?
I loved how he talked about surgery and used the metaphor of spaghetti, meatballs, and removing sauce.
So cool.
Yeah, and again, that's something that's relatable, right? That's something that I've never done brain surgery, right? And I can
You've never done brain surgery?
I haven't, yeah.
Shocking.
Jury's out.
Shocking.
But just think about it, right? Removing a meatball from spaghetti is easy. Removing a meatball amidst sauce from spaghetti and ensuring all the sauce gets out as well is impossible. And I think hearing that from a leading neurosurgeon at a top institution, it kind of normalized what they go through on a daily basis, right? I think sometimes people forget neurosurgeons are removing tumor. Like his job, his daily task is removing difficult tumors from people's brains. And to hear him kind of put it in a relatable layman's term, if you may, helped me visualize it as someone who knows about it and has funded neurosurgery work, but shows what they go through on a daily basis.
I thought it was fascinating because obviously, you know, both of us have been dealing with glioblastoma in one way, shape, or form for, let's say, give or take 5 years. And I've never heard it explained that way. And I remember I was just literally sitting in this chair and my jaw was kind of like dropped. I was like, this is so relatable. It's so easy to understand. And like, there's so many different analogies in regards to glioblastoma. And a big one is that it's like shaped like a star and it kind of has like tentacles. And like, we all understand that. But the way he explained it, I feel like was just so easy to understand. And it provides so much more clarity as far as like how difficult glioblastoma is. And it brings more perspective as to why it's actually so difficult to treat, in my opinion.
Yeah.
So.
And I think it speaks to the importance of technologies as well, right? As brain surgery is different. You know, we've evolved if we talk about change, right? And no change in so long. But brain surgery and technologies and machinery that's available is changing every single day, right? So we're getting to a point of cleaner resections. We're getting to a point of, you know, with connectomics, which he also touched on, understanding the pathways of our brain better, right? So that a neurosurgeon can do the work they do in a way that not only is removing a tumor, but I also loved he mentioned quality of life. That to me is everything, right? As we currently exist, quality of life is the only thing you have after GBM that needs to at least be sustained.
Yeah, for sure. Do you feel like in regards to your brother's glioblastoma journey, how was his quality of life post-surgery?
I mean, it's a great question, and I think it's something that everyone, mainly everyone that has an operable tumor goes through, right? And so his first surgery, reading the Wall Street Journal 2 days later.
Really?
Like, no issue. Back at work, riding the subway, 15 months of, if he didn't wear Ep.2, you would not know my brother had brain surgery, went through chemo, radiation, everything he had to face.
Yeah.
Second surgery, we went into it. We knew it. We accepted it. We went through our pros and cons. He read everything out. The surgery was a bilateral surgery, so his tumor was on the other side of his brain, right? So it wasn't going back into the same cavity. It was difficult. It was, you know, there was worries about motor skills. And, you know, right off the bat, I often say it with things we did with Stash Strong, he didn't know how to use a fork and knife. And so you take surgery 1, Wall Street Journal, back at work, surgery 2, figuring out how to use a fork and knife. And like that's a real thing that people face with surgeries, and it shows the invasiveness of surgery. It shows the difficulties of it. But his neurosurgeon, who is an incredible human and also on the Stash Strong board, went into that surgery ensuring quality of life. Right? And we knew, you know, there was going to be a little bit left possibly, but we wanted as many good days as we could have possibly with Jeej. And I think the way he went about that surgery ensured that. There was aphasia issues, right? There was a couple issues like that we had to talk to him. He's back running, right? He's golfing, you know. He just had to face some difficulties with speech, but his way was going to therapies, right? Getting better every day. And, you know, I always say metaphorically using that fork and knife to kind of carve himself back into who he was before. But it all comes back to like the importance of quality of life post-surgery.
I think that's a really great analogy too. I like how you kind of referenced the fork and knife as far as like the way he kind of like built himself up post second surgery, you know, as opposed to like even though that happened after that, but how you kind of like made it positive. I think that's pretty cool.
Yeah, and a lot of people go through difficult surgeries, right? A lot of people come to Stash Strong and surgery might not have gone as well. And that to me is like that stage 1, right? If you may, of like the first thing that happens to a lot of people. How can we get to a point of just like better understanding the brain? Connectomics comes into play. How can we better ensure surgeries are giving quality of life to give that patient a fighting chance?
Yeah. Being that you're around so many different, let's say, you know, brain tumor developments and, you know, like obviously you're working in the space now. Is there any particular, let's say, therapy or device or anything that you've seen in relation to surgery that you're like, oh, this is pretty cool?
Yeah, I mean, the number one thing for us and what I've seen in our medical advisory board is fascinated by is what we funded with the glioma connectome project. So we have 8 right now leading institutions that are using connectomics to better understand those pathways, right? So it's twofold. It's both going into surgery to understand how, the location of the tumor might impact speech, might impact, mobility, different things that would happen from that surgery, but then also treatment, right? So understanding, okay, I did this, I impacted these pathways, what treatments might also be available that can help based on location, based on, what happened there. So what is going on in the connectomics space from a surgery perspective, I think is, I know from listening to leaders talk about this, it's cutting edge.
Yeah.
It's a difference, and it's why it's something that we have been passionate about funding because, again, Stash Strong's one of our missions is to ensure quality of life for patients, and it often starts with surgery.
Love that. That's super cool. I think for me, this is just my personal opinion from what I've seen. I feel like I'm so fascinated by like AI. Doctors and surgeons will all put on these VR goggles, and they'll kind of inside the surgery. I think that's so fascinating.
Yeah.
So I'm kind of excited to see personally where that sort of develops over the next couple of years.
Yeah, that combo of AI and tech entering the brain tumor space is going to be very important, I think, to that reaching change.
For sure. Well, thank you again for joining us on another segment of Deep Dive with Stash Strong.